I wanted to start out by reviewing briefly my potential conflict of interests with you. So we do have a contract with the Department of Children and Families to conduct pre-consent reviews and medication consultations for children in foster care. That is actually something that has me appreciate the value of these guidelines tremendously. Also, I work on a subcontract where we produce quality indicators for CMS. I serve on some organizations, including parent-child interaction therapy and committees of the American Academy of Child and Adolescent Psychiatry, and serve as a member of the board of directors Gainesville-NAMI. So I think my interests are well distributed. What I'm trying to pack into the short time that we have this morning is review any new guidelines or reviews that have come up since we met on this occasion in 2016, and then provide an abbreviated literature review covering the time period from 2016 to 2018, and then we'll go over suggestions for updating. As Dan has mentioned, that's really what we're doing, is we're looking whether we need to update something. We're not trying to build a new house here. For those of you who may not have been here in the previous years, we do successively build on what we've done in the past. So for example, the literature review for ADHD started really quite a while ago, and it built on, so it built, for example, on very thorough reviews that were done by AHRQ, and then also the reviews that the American Academy of Pediatrics conducted for their guidelines. And then successively reviewed the Cochrane Reviews and did these literature updates that overlap to make sure nothing falls through the cracks. So that's what we're doing today, is basically filling in the last couple of years. In terms of guidelines, we are still from the AAP, we're still with their 2011 guidelines, which basically say that we should consider ADHD treatment by age groups, that for preschoolers ages 4 to 5, that we should prescribe evidence-based behavior therapy first, and that we may prescribe methylphenidate. For school-age children 6 to 11, FDA-approved ADHD medications and or evidence-based behavior therapy. And then for adolescents 12 to 18, FDA-approved ADHD medication with assent, and then may prescribe evidence-based behavior therapy and titrating doses to achieve maximum benefit. So basically, start up, but keep on titrating. Don't just put them on a certain amount and then see them in a half a year. So no new guidelines. The American Academy of Child and Adolescent Psychiatry, they are working on updates, but those are not available at this point. In terms of Cochrane reviews, between 2016 and 2018, there were 3 relevant ones that were conducted. One was examining methylphenidate for ADHD from non-randomized studies. This then looked at 260 studies that included over 2 million children, and they basically they spoke to, in comparative studies, the risk ratio of serious adverse events for methylphenidate, and then also they looked in non-comparative studies what actually was the what was the rate of serious adverse events, and I think the important piece here is also that, unfortunately, like in most of the Cochrane reviews that have been conducted for the topic of ADHD and for probably most of the mental health related topics, is the conclusion is that the certainty in evidence is very low. There's always the conclusion that the studies that are included have all kind of shortcomings. So here we have a finding that we might confirmed through our clinical experience or not of serious adverse events occurring in about 1 of 100 of children prescribed methylphenidate. There was also a Cochrane review on pharmacological treatment for children with ADHD and comorbid tic disorders. I think that's a topic that is getting a bit more steam, the question of what we do when we have a child with ADHD and also with tic disorders. And here the conclusion was that stimulants appear to improve ADHD, have not been shown to worsen tics in most people with tic disorder, which of course doesn't mean that for certain individuals that might not happen. And then lastly, a review on methylphenidate for children and adolescents with autism spectrum disorder, also a hot topic because we now can diagnose ADHD along with ASD. The numbers of ASD patients are going up, and here, not surprisingly, short-term use of methylphenidate might improve the symptoms of ADHD, in particular hyperactivity, possibly inattention, but does not impact the core ASD symptoms. So Cochrane Reviews don't provide anything that I would think are going to change how our guidelines read. In doing a literature review for children under 6 years old, basically identified 32 records, of which I discarded everyone because they were either not for preschool children, did not really cover ADHD, were addressing parenting interventions, and I think that's noteworthy. That's really where the publications are, that's where the publications need to be. And so basically nothing new in the literature review for the under 6-year-olds. So basically, the discussion points, what I was suggesting from reviewing this was that our recommendations for level 1 parenting interventions, they're really still consistent with strong evidence. So that refers to our level 2 conducting assessment, facilitating family engagement, and then level 1 provide parent management skills training or other behavioral intervention at home and or school for a minimum of 12 weeks. So there's nothing that would say that should not be the first line of approach for this age group. That doesn't mean that this doesn't happen all the time, unfortunately. There were also no new studies that would support moving amphetamines to level 2. So for level 2, we have initiate monotherapy with methylphenidate formulation. And as you probably recall, that is based on the fact that even though Adderall has the FDA approval for the younger age group, we don't have safety studies, we don't have efficacy studies, and this is based on the results of the PAT study. So we have level 2 monotherapy with methylphenidate formulation. A question that I think would be worthy of our discussion here is whether to refer to extended release stimulants. We don't have any new research evidence about that. The ACAP guidelines, they speak vaguely about it, and I can tell you that in the reviews that we're doing for the foster care population, it's amazing what all people are putting little kids on. So it definitely comes up, and from the angle of if we're providing guidance to our colleagues, and the people that are doing the reviews, we're all board certified child and adolescent psychiatrists. So we feel strongly that we don't want to just boss our colleagues around. So we want to guide with evidence. And so what do we do about the long-acting stimulants there? Evidence doesn't help us with that. And then the other question is include extended release alpha agonists. So we currently, we're basically saying for level 3, if methylphenidate is unsuccessful, consider monotherapy with atomoxetine. This was based on literature that we reviewed a couple years ago. So there is data on atomoxetine, including some efficacy and some safety data. And level 4, consider amphetamine formulations that have FDA indication but limited clinical trial evidence, may consider alpha-2 agonists. Again, no published data available for this age group. And then we said not recommended antipsychotic medication to treat core symptoms of ADHD. And this one also, I would like to have some reflection on not recommended concurrent use of 2 or more alpha agonists, given our spirited discussion last night. My sense was that we don't really have anything new to stand on to change this. It does put us really, it has us hold a strong stance against what is being done in clinical practice. Because I'm not sure if you're aware of it, but we're aware that there is a lot of prescribing going on for this age group. A lot of pediatricians jump right at Adderall, and then we do the education about why it should be different and refer back to these guidelines.
Could you share with the group why not recommending 2 or more alpha-2 agonists using guanfacine and adding?
How that entered into, yes. So that we discussed a couple years ago, and it's a common practice. And then what we have observed is that the dosing for that, for one, is that they're being used as if they're independent medications, so that you can utilize the maximum doses for guanfacine plus clonidine simultaneously. So that obviously becomes problematic, but we don't have official guidance on how you should do that. The assumption is that it's a good thing to do because clonidine gets treated as a sleep medication and guanfacine gets treated as the daytime medication, without there being efforts to try and see whether you can actually get along without starting that interclass polypharmacy. So we put it out there, but that guidance is not based on any formal studies. It's based on observing worrisome patterns and common sense.
It says that probably in the, I feel like I've seen that written like on package inserts or things that you're not supposed to use. It's just like you're not, just like it says you shouldn't use guanfacine ER with guanfacine, or
yes.
ER with clonidine,
Mm-hmm.
when really you could if you're, I mean, people do it if you're back, if you have good knowledge in the area, but this is just because we're putting that out there so people who aren't very accustomed to treating this, have a caution.
Yeah.
Or that they or caution people that need to document why they're doing something, that they have made a trial of one medication.
Yeah. You had your hands up?
Yeah, I was wondering why atomoxetine is on level 3 and the agonists are level 4.
That was based on the fact that we do have published clinical trial data for atomoxetine for the age group, but we don't have it for the alpha agonists.
But the ADHD guideline seems to suggest that after we exhaust the natolfin, the stimulant, we can augment with the alpha agonist.
Oh, yeah. Well, it's the pediatric guidelines can only stand on also whatever evidence is there. So I think probably their expert group looked at this and felt comfortable doing it the other way around. Yeah. Yes?
So several comments. I fully agree with not taking 2 alpha agonists and letting, as a general, I think we should warn against it. It's like everything else in pediatrics, whether it's even acetaminophen and ibuprofen, which are 2 different classes that confuse parents and states of making. That's the biggest issue I see. People having guanfacine and clonidine for patients and other problems. The other question I have is on the XR, because our hands, I guess step back one to your level 1 or level 0 with parenting. fully agree with that with preschool, but the problem is what we talked about last time, availability, access, long waiting lists to get children to have therapists, whether they're at home, at school, and so forth. So, and if we get kicked out of the preschool, our hands are some of the time. Although we've always recommended therapy, parenting. So that's a question, and I guess I don't know if it's a purview here. Certainly, it would be great if we could come out. One of the themes I'm hearing is that we need more access to therapy for lots of students. I don't know if it's a purview even too political on this group, but it's something that we should maybe try to put out as a recommendation. So I think that would really help.
So can I ask for clarification? You talked about extended release, but also about therapy.
Yeah, so I was going to get to the city. I'm sorry, I'm skipping around. I apologize for that. My question is, are there any, I know there's no evidence-based, because there are no studies on extended release, but are there any negative ones? Because that does become, after we've tried parenting, tried short-acting, multiple short-actings, we have to, defer to SIDS before we do extended release, especially for children. So my question is just like so much here in preschool age, is there anything contradictory about extended release?
We don't have data. One could start looking at use of it, and you could look for adverse outcomes in databases, for example. We currently don't have studies. I guess what I would ask is, what would stand in the way of just using short-acting methylphenidate? Or are you concerned that it becomes a problem of re-administering it for them?
There's administration in private preschools, there's not much medical. I mean, we do it. I mean, we write to give it, and some preschools won't administer it, that's number one. And the same thing we have in kindergarten. We're fortunate enough in Palm Beach County to have a school there, but it still becomes an issue. But it's after failing giving short-acting twice or even 3 times a day. And we all know whatever, it's unusual. It's the same medication, same dosing regimen. Sometimes when you go to extended release, you get some better results. And vice versa as well. But I mean,
Okay, so that's helpful. In terms of having group agreement that this stay level 1, is there anyone who would have any concern about that or recommendation? So we're good on that. Level 2, initiating monotherapy as a first trial, still good on that?
I would also, the only thing I would add is if that's the intent, which I think it is, I would say short-acting on level 2. Yes. That could be misleading to...
With short-acting, yes. Yes. Yes, and we do have that when we get to the dosing suggestions. Yes, yes, very much so. So level 3, also still okay with that? Yes. So then we're moving to level 4. Consider the amphetamine formulations and consider immediate release.
Is that what you recommend?
I would recommend trying to see whether you can do that, and then we could add we could add a comment that if immediate release have been tried and may consider long-acting. My sense would be that we would have to add a caution to stay within the recommended dosing limits, because I think that's really dangerous right now, especially because of the interesting formulations that have come out, like a liquid long-acting. I could just see little kids getting completely snowed with too much medication. We won't go into a lot of it, but just Andy, so that basically provides the dosing guideline that's based on the PATS basically, and then we had a discussion about the amphetamines. Studies for children ages 6 and older, basically in the literature review that I did for this, that identified more, 150 records, and then a large number of them discarded. You see the reasons for that. Gives you a little bit of an idea of what kind of things are happening. Neurofeedback, meditation is gaining quite a bit of steam. I reviewed 31 full-text records, and actually I also didn't include any of them because none of them had anything in it that would make a difference to our guidelines here, and again, to just give you a flavor of what the studies concerned, we had pharmacokinetic studies, efficacy and safety studies on some of the newer medications that have come out. There were 3 studies that were based on the original McCracken combined stimulant and guanfacine administration with some additional described outcomes. Interesting, but don't make a difference to our guidelines. Some long-term safety, efficacy, and adherence studies of medications that we already have in the guidelines. As I had hinted at, autism and ADHD is garnering a lot more attention. So there was a study on long-acting liquid methylphenidate for children with ASD and ADHD, and an atomoxetine study, and then 15 others that had different interesting outcomes, but none of them, again, would have made a difference in our guidelines. So similarly, as for the young children, I think our suggested treatment levels stay unchanged. We don't have new medication classes. We have some new packaging of our old medications. We don't have new comparative effectiveness study results that would make us ratchet around what we consider level 1, 2, 3, 4, 5. And then really the other thing that happened was updating our medication section, because for the ADHD medications we have a section where we spell out every medicine, so that was done, and we don't need to have a big group process to test our attention span for that. So we have then, the way it currently stands is level 0, comprehensive assessment using recommended rating, including using recommended rating scales. No new scales on the market either. Family engagement, treatment response monitoring, and then level 1 would be the psychostimulant monotherapy. And here we are silent on what class, unlike for the preschoolers. And we're also silent on immediate or release, or here we say short or long acting.
Yes, we do. That's right.
We could.
What terminology would you refer?
I think we should use the same one across the board.
Short or long acting, immediate release, extended release?
Immediate release, extended release.
Okay, so for consistency, we'll
Yes.
change that?
Yes. And then if first choice ineffective, try monotherapy with another stimulant. And then we also did speak to if supplementing the extended release, so we just have to change it wherever we say long-acting. Extended release with immediate release, that we stay within the same drug class. So this cocktail that comes across of mixing methylphenidate and amphetamines is not recommended. Level 1 could also be the extended release alpha-2 monotherapy. We had preserved the combination of alpha-2 with psychostimulant as a level 2. We have the one study, the McCracken study, that studied this in combination. One clinical trial. I personally think it's okay to leave it at level 2 because we are going into polypharmacy if we recommend it right away. But then if clinically, we all know there may be children that we see that we go, this is a candidate where that makes sense from the get-go, and then these levels would not prohibit us from doing that. Yes?
You need to clarify on next thing on level 2, just as atomoxetine, you need to clarify that it's augmentation with atomoxetine and not monotherapy?
It's monotherapy with atomoxetine.
So you're saying add monotherapy there after atomoxetine monotherapy?
Yeah, because we're talking about augmentation.
Oh, I see. You're saying combination with psychostimulant. You might think that this means combination of psychostimulant. Sure. I think that's a great suggestion. Yes.
Okay, go to monotherapy.
And then level 3, immediate release alpha-2 agonist as monotherapy or combination, which is This is different from here because this is the extended release, and this is the immediate release. And then level 4 diagnostic reconsideration, consider bupropion or tricyclic antidepressants, except for diazepam. And then not recommended antipsychotic medication to treat core symptoms. I feel very strongly that that needs to stay in there. That is like a bulwark against, there's a lot of that going on. It's very alarming to see how much of that concurrent use of 2 stimulant classes and the diazepam.
That last line, or since it's on both level 4 and
yes.
not recommended, it's a little bit of a duplication.
Yeah, I think that
Where would you prefer it up
I would leave
for?
it here because we're speaking about tricyclics here.
Right.
Mm-hmm.
And so remove it at under not,
Yes.
not recommended.
Mm-hmm. Yeah.
Remember, more words is not always better. We always try to have enough information to make it useful, but not too little information either.
Yeah. Now, from your practice experience, does this cover, if you don't mind, go back to the, does that cover about what we need to get ADHD corralled within a...
Are tricyclics still being used enough to put that in there at level 4?
So I can only speak for the experience with children in foster care. It doesn't come up a lot. It comes up occasionally. And because we're trying to also cover the scenario where you have children that are failing the usual treatments, I would leave it in there. If we take it out, it's still going to be utilized.
You feel the guidelines address duration of treatment adequately? Like how long does a child stay on medication if they're doing fine on the medication first? And then do you try and allow that again? Does it address it?
Yeah, so as you notice, we are silent on that for the group of the 6 to 18-year-olds. We did speak to it in the preschool age group. So that would not be something that would be my opinion. I think that would be something to the group as a whole. I know that clinically there is a rhythm to a child's life with school, and that you basically, and families impose a rhythm because they have desires to over the summer see what's really needed. I would find it difficult to put that in there as a recommendation. Like, I would not say that for a child in this age group that after 6 months of successful therapy that we should take them off, because we know that this is a chronic illness, that the likelihood of them experiencing an improvement or remission is much, much slower. So what are some other thoughts on that?
The numbers show, your patients are going to be non-compliant at some point, so parents are going to get an opportunity to see their kids on and off and use stimulants.
Mm-hmm.
On holidays or just because I'm not taking my meds, so I don't think you can put it in there because it happens.
Yeah. Mm-hmm.
I think the issue is for the younger group, the potential for misdiagnosis, or if it, because they're so young, it may have been developmentally normal, it may have been environmental context or foster care or something else. And so I think that's why we have it in the younger age group, whereas you're more firm and this is the diagnosis.
Mm-hmm. Mm-hmm. Did you have something in mind that you were hoping to see there?
Well, I think it's up in the air since we don't have any biological markers to support, this is a diagnosis based on symptoms, right? And the symptoms are resolved for a period of time. And I mean, what you're suggesting is this is a lifelong illness. ADHD, a lifelong illness?
No, actually, because we're talking about 6 to 17 years here, I think the age group at which we might expect to see additional maturational changes is after that. That's why I felt comfortable that we don't need to have something specific in there.
Do you want to take a vote on that? You want to move along in the last we have
I
about
just
3
had a
minutes?
comment. I'm sorry, I've been raising my hand. Level 0, I would include comprehensive assessment, including a detailed developmental, educational, and symptom history. I think that a lot
Educational
of
history.
times- Yes, but a lot of times the problem is that kids present with inattention, but they have learning disabilities and they can't focus in class. So I think we need to add that educational.
Okay. Can we have a brief show of hands in the interest of time? Does that suggestion strike gold here and you're in favor? Who's in favor? Anybody opposed? Okay, the in favors have it. I think that's a very good suggestion to add that to the history.
Thank you very much, Dr. Bussing.
Regina.